Welcome, and thank you for joining us today for the webinar, NCI Multi-Level Geospatial and Contextual Webinar Series, Emerging Methods of Exploring the Team Microenvironment in Cancer Care. My name is Stephanie, and I will be your WebEx host today. Before I move into introducing our speaker for today, I'd like to make a few comments before we get started. All lines have been muted upon entry and will remain muted for the duration of the webinar. You can submit questions throughout the presentation in the Q&A or chat panel on the right-hand portion of your screen and select all panelists from the drop-down. We will ask these questions on your behalf after the presentation and during the Q&A portion of the webinar. If you need to view live captioning, please refer to the Media Viewer panel on the right-hand side of your screen. This webinar is being recorded and will be posted online in the near future. And now I'd like to turn it over to Dr. Sally Weaver for a brief introduction.
Thanks so much, Stephanie, and thank you all for joining us this afternoon. We're really excited to see the number of attendees that are on the line today, and we have a really great speaker for you. It's my honor to introduce to you Dr. Michael Rosen, who is a Human Factors Psychologist and Associate Professor of Anesthesiology and Critical Care Medicine at the Johns Hopkins University School of Medicine. Dr. Rosen's research and operational work focuses on teamwork, performance measurement, system evaluation and design, as well as implementation and change management, organizational leadership, and operational management strategies for patient safety and quality. He's a core faculty member of the Armstrong Institute for Patient Safety and Quality and co-director of the Master of Applied Science in Patient Safety and Healthcare Quality at the Bloomberg School of Public Health. He also is Associate Director for Team Science at the Johns Hopkins Institute for Clinical and Translational Research. And so with that, I'm very excited to turn things over to our guest speaker today, Dr. Rosen. Dr. Rosen?
Really, I'm really looking forward to this talk, and I greatly appreciate the opportunity to kind of share some of what we've been doing and kind of expand on some of the ideas that we're able to kind of put together for a recent chapter for Dr. Bergen's and Berger's book. So a little bit of backstory to where this is and where it's coming from. You know, I spent the last 15 years or so of my career developing different types of measurement systems and interventions to kind of assess and improve teamwork in healthcare delivery systems. And a lot of that, the preponderance of that, has been very traditional measure development on observational rating systems or survey tools, and then using those measurement systems to kind of drive improvement. Those are all good things to do, great things to do. They're also very kind of labor intensive and therefore costly, and there are challenges to scaling those types of approaches. So over the last 4 or 5 years, myself and many of my colleagues have drifted more into looking at other types of data that we can use besides having raters assess performance or having individuals assess their own performance on different types of things. Is what can we do with the newer, potentially lower cost sources of information. These are wearable environmental sensors. These are, the quote-unquote found data that exists in information systems, and how can we use that to translate that into to build valid measurement systems that do scale and that are kind of informative and helpful. So that's what I'm going to talk about today. I think in many ways we're in a really exciting time for all of those methods. Social sciences in general are behind engineering some of the physical sciences and adopting some of those methods, but there's a lot of work going on, and there's a strong need for more coherent approach in understanding what the options are for measurement and understanding some best practices in capturing this type of data effectively and using it for healthcare delivery system kind of evaluation and improvement. So all of this work happens in a team, and have been fortunate to have a great list of collaborators. There's a short list here of the internal Hopkins folks, and for one of our projects, our NASA-funded work, we work with a team at Rice that's very experienced both in measurement and in teamwork. This work is a mix of funded research projects that I'll talk about today, but also some operational projects that are much less rigorous, but I think good examples of how to apply these methods to an extent. But we have had some projects over the years in this space funded by some great adventurous people that have had some good faith in us to do some different things. So today what I'd like to do is very quickly up front, just kind of try to map out the space a little bit of what I'm talking about, with some definitions of the key concepts, and also social data science methods. And part of the challenge is maybe that's not the right phrase to describe this whole piece of work, but I think that's the challenge, is there needs to be a focus in this area of methodological experts, of content experts, of clinical domain experts working in this area in a unified way, which is not exactly what we have now. We have lots of people doing lots of neat things, but it would be great if we could pull these together and have a field or a focus in this area. So I'm going to talk about some of the basics that kind of map out this area, and then I'm going to just talk about some examples of the work we've done in this over the years as how you can apply those different types of sensor streams and found data streams to important problems around individual and team workload and stress and resilience. We also have some work in the area of shared decision-making using linguistic and paralinguistic analysis. And then the last two we'll talk about are very much more applied operational needs, looking at coordination around multi-team systems and how a healthcare system can use some of its own data to better prioritize where risks are around coordination failures, and event reporting analysis, doing natural language processing on that for extracting measures of climate that can impact team functioning. And they'll talk about some high-level future directions too for, again, trying to, I think what's needed is collect a lot of the work that's being done and focus that into a field to an extent. So some definitions and some challenges and some methods around the team microenvironment. And to be honest, we're not here cancer researchers, so we were gifted this phrase of the team microenvironment by Dr. Berrigan and Berger. And we had to look up what that phrase was. We're not cancer researchers, but we think there's a lot of value in thinking about what a microenvironment means for a team and how that fits into all of this. So there's very broad strokes. We know there's ample empirical evidence in many reviews that the quality of the teamwork impacts overall safety and quality in healthcare delivery system. I'm not going to spend time establishing that point. It's there. And this idea of what a microenvironment means for a team, we kind of take that to be the collection of factors that are really exerting influence on the social interactions of people participating in care delivery. So it really is about the enabling infrastructure and the supportive context that either sets people up to perform well in teams or does not, or undermines their ability to coordinate and communicate and perform effectively as a team. As I mentioned briefly, this is kind of a known challenge. It's very important for healthcare delivery systems, but both the research and translating research into operations have been constrained by the measurement approaches, and that they're typically either very costly or done at such a low frequency that they don't really inform practice very well, or they're not able to scale a research project across many organizations because of the costs involved in collecting data. So that brings us to the potential contribution for what I'm broadly kind of talking about as social data science or computational social science. They're more or less interchangeable to an extent. It just depends who you're talking to. If I talk to a hospital operations person about computational social science, that conversation is not going to go too far. If I talk to them about social data science, they'll forget I said the word social, and they'll hear data science, and they'll be interested in talking to me some more. So that's one of the reasons we're using this phrase at the moment. But really, we're talking about blending approaches for generating insights from larger structured and unstructured data sources, and using those exploratory generative methods many times and theories from human behavior and social sciences to understand behavior and interactions at multiple scales. So the individuals acting with teams, the teams interacting within larger multi-team systems and organizations and cross-organization interactions. And in a lot of ways, this is a social systems analog or a healthcare delivery systems analog to the advancements in the pushes in precision or personalized medicine. All the emphasis on those methods and on that computational infrastructure for that, which focuses on clinical data, rightfully so. This is the same approach focused on healthcare system delivery performance data. So we think there's a lot of value in doing this. And from a team measurement perspective and in the team science, the main focus is on this idea of unobtrusive measurement. So these are collecting data from people that does not require them to provide a clear response. So you're not asking them to answer questions, you're not asking them to fill out a survey. they're doing what they're doing, and you're collecting data about what they're doing as they're doing it. And this is the inputs, mediators, outputs framework that has been a part of the team science, the science of teams for decades. It's a very high-level organizational framework, very similar in nature to structure, process, outcome model of Don Obedian for healthcare quality and delivery systems, but it outlines at a big picture the content that you would want one of these systems to measure if you're interested in understanding the microenvironment of a team and impact that that environment has on the team's functioning. So a lot of stable characteristics under inputs are everything you can imagine about describing the attributes of the people involved in that team. Of course, their professional training and background, but also their personality and competency levels, their history working together, the structure of the team's task, the technology they use, and the work processes that are in place, and then also the more macro context that the team is situated in. So things about the leadership of the unit, the division, the organization, and the culture and local climate that establishes the norms for how people interact in that group. There's all those types of things that you can measure, and those are, many of those, some of those are measured through kind of found data systems that are administrative data. Others are not. And the mediators are how we interact as a team together. So our action processes are how we execute a task, our transition processes and how we move from one task to another, and our personal processes in terms of how we treat each other as individuals and manage conflict and those types of things. And there's a bucket of affective and cognitive emergent states around trust and our shared situation awareness, how we understand what's happening in a situation, are projecting that forward. All those types of things are good to targets to potentially measure with these types of systems. And then, of course, those things all impact outcomes that we care about. So again, the traditional way to measure this content is with survey or observation. But if you start asking what else can we use to measure these types of or components of the team microenvironment, in our work, in our experience, it comes down to four kind of broad domains that are at play now and will be. And these are kind of various stages of maturity and use. Across the board, though, there's a lot to learn about how to use and validate measures generated from these types of data streams. But there's linguistic communication, which is really about the content of what we're saying and the specific style, the word choices we make. There's paralinguistic communication, which is largely about how we're communicating emotion non-verbally, but not just that too. There's also shared understanding with gesture and gaze and those types of things. There's physiology in teams. This is a really interesting area. It's a bit complicated, but there's a lot of work going on in this area. You can really start to understand things like emotional contagion and other things like that, and who is influencing and creating conflict, and also, of course, things like workload. So there's a lot in team physiological dynamics. And the last piece is activity tracking, which can be a wearable or environmental sensors, but also information you extract from largely the electronic health record or other information systems that capture something of what people are doing through the day. And you can build measures of coordination, you can build measures of workload and work process from those types of things. That's much more of a bespoke process that's kind of custom built based on the availability of different information systems, but there's a huge potential for work in that area too. So quickly, I'll go through examples of the types of things that are covered in each of those four domains, and then we'll switch and starting to discuss how you apply those across different types of research or applied questions. So for the linguistic communication, what team members say to one another matters quite a bit, and there's decades of literature that fills kind of the letter of the law of being an unobtrusive measurement system, but not really the spirit. So these are communication analyses that are done off of manually coded transcripts, extremely labor intensive. There's a huge research tradition on that, and those types of measures predict outcomes. In healthcare, there's things like the Rotor interaction analysis system for physician and patient communication. Those types of things are done in teams too. Not that physicians and patients aren't teams. But so there's a lot there to learn from, but it's still incredibly labor intensive and not scalable in any way, shape, or form. But then there's some other things that are a little bit more scalable and automated that can be done on a text representation of communication, whether that's from email or messaging systems or real-time kind of transcription is getting better, not quite there yet, but getting better, and some of these will be applicable more broadly soon. So non-domain specific content around the use of different types of words and around pronoun use and around structural word, functional word use, which have a very social content. And we'll talk about some examples of how those play out in our work a little bit later. But also the similarity in word use, which we talk about style matching. Are we just talking the same language when it comes to our style of interaction? It turns out that that predicts task outcomes and affective outcomes. And in some of our work, too, predicts perceptions of cultural dissimilarity between patients and physicians as well. So there's a lot to be done in just linguistic alignment or linguistic style matching, too. And then some in the sequence of word use, closed-loop communication, which we know from a lot of the aviation world, but gets applied in kind of code teams, emergency response teams, and hospitals, very, very important things. So what team members communicate without using words matters a lot too. And two of these we use very frequently in our work, which is communication flow and vocal features. So communication flow, things like egalitarian turn-taking in a problem-solving team, if we're trying to come to consensus on what is happening in a situation or what we're going to do, it helps if there isn't a dominant person in that conversation. Those teams where turn-taking is shared do much better. Also, teams that don't have a structured process of following turn-taking do better too. So if we're more flexible in who's contributing when, we actually have teams that do better when that's there. In the vocal features, there's a really fascinating field called computational paralinguistics now that looks at large feature spaces for voice signal analysis, and they build extremely predictive models off of that for affective states or personality, things like that. It's not the most intellectually satisfying because these are black box models usually, but it's encouraging that there are the possibility to build really useful measures of individuals and team interaction based on the vocal features. So we're experimenting in some of that area too. The middle two, facial expression and gaze behavior, you can see there some of the markers of effective and ineffective teamwork. Those don't come up for us very often just because there's not usually an easy way to capture that data, but it seems incredibly relevant for things like telehealth solutions, similar for gesture and posture too. So the physiological dynamics of interacting with teams matters a lot too. We just published last month a review of this literature. We won't spend too much time on this because there's huge methodological challenges here and the inconsistent findings because everyone's processing this data differently. But at a high level, there's good encouraging evidence that it matters a lot. It can be associated with outcomes, different types of outcomes. And this, people look at both just overall physiological activation in a team as indicators of things like workload and how that relates to outcomes, but also they look at the idea of synchrony. So my physiology is synced to my teammates' physiology. That has different implications for our performance in different types of tasks. And even further than that, looking at synchrony of physiology within a group or a team, who is predicting whose physiology matters too. So if the team is following me in terms of my physiological activation, chances are I'm not being a good team member because everyone is forced to synchronize to my state and my level of activation. So there's some preliminary data that who is driving and who is following physiological synchrony is an important indicator of team performance and who may be causing conflict within a team. So lots of interesting things here. Some of the physiological signals are more practical than others. I do not foresee a time where I'll be strapping people to EEGs while they go about the hospital, but wrist-worn electrodermal and cardiovascular sensors are getting better and cheaper. and we're using some of them now, but that's increasingly an option for some types of studies. So the activity tracing piece is, again, a bit of a bespoke thing, and we'll talk through some examples of how we do this, but it gets used to detect where there might be areas of team risks. So it's done in transmission of infections in acute care wards. People mine electronic health records for measures of workload, also team coordination, so who is shared documenting and shared accessing the same things to understand how people are coordinating work, using wearables for physical work process mapping. And what's really kind of interesting, we're excited about pursuing too, is using a lot of just administrative data to identify patient paths through the healthcare system and looking at different types of risks associated with different patterns of access of healthcare or movement through the healthcare system. So that's a lot, I know, but we'll walk through how some of these, it's rare that you use all of these in any one project, but we have several kind of streams of work where each of these are more or less relevant. So one big bucket of work we spend a lot of time, this is where most of our funded research in this area is, on the general topic of individual and team workload, how that impacts their stress levels and what they do to cope with that stress, so their resilience under stressful situations. And this is done at the individual level. So we look at nursing workload with an ICU study, where we have current projects going on now with internal medicine residents, looking also at their patterns of work and how that impacts educational and well-being outcomes. We have a team-level workload study in our pediatric intensive care unit, which will talk about how to scale some of these sensor-based individual measures of workload to a larger collective. And then we have a project actually on astronaut competency assessment using these same data streams for NASA. I talked about, too, we can use linguistic and paralinguistic analysis in physician and patient interactions to look at both perceptions of the quality of that interaction, shared decision-making outcomes, and actually health outcomes, too. And then the last two are more applied projects, looking at administrative data, so activity tracking in one form or another, and how staff within different areas perceive the quality of the handoffs based on the nature of how they're situated with the units that they're handing off to one another, which we'll talk about. And then we'll also talk about how we're trying to detect climate issues in patient safety event reporting data. So starting off, I probably don't need to spend too much time on outlining the challenges around workload and the state of the industry today. There's staff shortages, there's burnout, there's potentially mental health crises in the across the industry. There's a lot of challenges currently, and we know that workload, conceptualized and measured in different ways, impacts patient experience, hospital-acquired infections, delays in treatment, post-op complications. It also impacts the people in that system. Working under those conditions with increased burnout, job satisfaction under high workload conditions, turnover, disengagement and exiting the professions, and then organizational efficiency and productivity too. Most of the used kind of currently applied systems for assessing workload rely on things like staffing ratios. There are some observational systems, particularly for nursing workload, and some survey methods to look at observation. But we want to try to find something better. These are either people's perceptions or they're looking at the inputs to the system. So what's the mix of patients I have today, but it's not measuring the processes we go through, the work we do to manage that workload. And that's where these types of sensor systems can really benefit. So this is a study done a few years ago now. It took a while to get published, which is another challenge of doing work in this area. It's innovative and that has pros and cons to it. But this is, so on the right, this is the sensor we use in the study. And if you've spent any time in this area of social sensing systems, you recognize this. This is one of the first, if not the first, system put out there. It was developed by the MIT Media Lab and commercialized at the time as Sociometric Solutions. Now they're called Humanize. For the time, absolutely brilliant. We'll talk about what it captures in a moment. But severely limited device, but it opened the door for a lot of possibilities and a lot of work, and for that we're really thankful. So what we did is paired on the left-hand side a traditional kind of experience sampling method where we looked at attributes of the ICU work shift, and over time at 3 time points within that shift, the nurse's experience of physical and mental exertion over time. So we're looking at within individual and between individual variants in their self-report variation in mental and physical exertion. We capture patient factors like the level of care, and we did some focus groups and literature reviews to know these are the task factors that generally are believed to impact workloads. Are they on an insulin drip protocol, a ventilator? Are they vasoactive? Do they have a PA catheter? Are they on dialysis, or do they have different flap checks? And then some shift factors, those things that will carry out throughout the whole 12-hour shift, the number of patients they have, and then we looked at a composite of the number of patients by all those different factors I just talked about. Did they have help? Did they have a nursing assistant at any point in time? And then also rounding, because that's when that happened in the process, because that's a known big source of workload. And then every 4 hours, they just filled out, it was a single item measure of mental and physical exertion. But again, this is the challenge with this data is getting people to respond. So we went with a very light survey form and lots of sensor data. So this is an image of the unit where we did this study. It was a surgical ICU, a lot of tumors, but also some transplant. And we sensorized, we put those badges throughout the unit, and then we had staff wear those badges as they walked around. So there's 2 main nursing workstations, 3 little desks at each side. The areas in the middle are a medication room, a supply room, and a nutrition room, and then there were sensors in all of the surrounding physical rooms. The non-censored rooms at the bottom right were isolation rooms, which we didn't use for logistical reasons, and the top left were our office spaces and overflow rooms that didn't get used for patient care. So everything else was kind of off the grid. So the nurses wearing those sensors around the room, what type of data is kind of coming off of those sensors? And again, that specific system is not really widely used anymore, but the types of data streams are very much the same. So this is just essentially our best effort at a scatter plot for the data, the raw data you'd see off of this system. And it takes a little bit of getting used to read, of course, but what you see is each little segment around the outside of that circle is an individual. And as you traverse that little arc clockwise, that's time. And this represents about 6 hours of data for 12 people. So each little outer blue mark is 6 hours of data. Each little segment is 1 person. The little heat map immediately inside of that is a heat map of accelerometer data, so motion data. Within that sensor, there's a package. There's an accelerometer, which is an accelerometer in everything these days. So you get some gross level of physical activity and movement. The histograms that are immediately inside that heat map are the proportion of time spent speaking. And this is where the sensor system struggles a little bit, but there's an effort to just understand, are they speaking, are they not speaking, so you can get some communication flow data. So each little histogram stack is 10 minutes, and the length is a proportion of that 10 minutes they spent speaking. The heat map inside of that histogram is around vocal pitch. So you can see, are they speaking, and is that an elevated pitch or not? And then the lines connecting the people at different time points are times where they were co-located. So a lot of data coming off of that very simple system, or this very small device that people wear around their neck. Again, that specific system would not recommend using, but all of these sensor streams are very much important, and you can get in different, better ways now. And from all that raw data, you can generate lots of different types of measures of interaction. Again, for us, for this study, we were focusing primarily on individual level workload because some of that specific system, some of the issues with the speaking and the interaction measures are actually where it was weakest and not performing that well, so we didn't use those, but some of the other ones were perfectly fine. So what we did to analyze all that data for the nursing studies, we had 89 4-hour blocks across 35 shifts, so that was 356 kind of work hours. We created a set of sensor features of 72, and looked also at all the pairwise interactions amongst those sensor features, and used elastic net methods to avoid overfitting that data. You have a lot of indicators of the outcome, which in our case is perceived mental and physical exertion. You don't want to overfit that model, so there are ways to do that from the data science world to at least some extent. And then we use multi-level modeling to look at kind of within shift variance in that experience of workload, and between shift variance in that experience of workload. And then all the level 1 predictors, so within the time block were the sensor-based features, and then the level 2 predictors, which were at the shift level as a whole, were all those task demands that stayed stable for that whole shift. And what we found is that roughly a little bit more than half of the variance was really between shifts. So you definitely, there is such a thing as not surprisingly, there's a tough day and there's an easy day. And we were able to do a really good job predicting the between shift variance of detecting which days were really bad and which days were relatively easy for the mental exertion. And we predict about half of the variance both within and between shifts for the physical exertion. So that's kind of a lot. So and this was in addition to those traditional measures of workload, which were things like patient stat ratios and things like that. So this interaction data is extremely predictive of people's experience in this area. And there's some overall patterns of interaction that were predictive of exertion, like the burstiness of speaking. So that just means how clumped up in time is your social interaction with people. If it's really clumped up in time, that's an indicator of increased mental exertion. And then one of the really interesting ones to me, which I think has a lot of utility for other areas, is just looking at the entropy of transition. So how organized is my movement through a physical space, and the burstiness of those transitions. And these were just movements from one physical location to another. If I had a highly unorganized, high entropy and high burstiness, I was having a really tough day. And that's, I think, an important indicator that's somewhat generalizable. We're gonna find out, but we think that's pretty generalizable. And then there's some really context-specific interactions that matter too. So the burstiness of speaking was much more predictive of exertion when you had a patient on an insulin drip. And this makes a lot of sense when you know the workflow involved in the nurse-driven insulin protocols. Part of that is finding, it's an hourly protocol that has to be done every hour, and it involves a nursing double check. So they have to go find someone, interrupt their work, bring them back, and go through this protocol. So that's a big part of, if you're having a tough time finding someone, you're having an extremely difficult day. So those are some interesting findings from a system that itself does not scale, but the actual signals it represents do. So for example, we're now moving on from the nursing world to the physician world. This is a study that's this is a pilot study, but there's ongoing work now funded by the American Medical Association and their Back to the Bedside initiative. This is part of a learning collaborative on resident education and work life. And the issue here is just one, understanding their patterns of work. You can no longer buy the sensors we used, and we wouldn't use them anyway, but we have an inbuilt location tracking system that started off for tagging expensive equipment on wheels that would disappear, and then it moved out to expanding to tagging patients that would go missing every once in a while, to now kind of a lot of staff can use these, and you can get information about your workflow. So using some of that full spectrum, we're no longer getting accelerometer data or communication data, but we're getting physical location data at a much bigger scale. At the bottom left, you see the $25 badge that we can afford to buy for all the residents is a much better deal than the $500 sensor badge that we couldn't. That was very high maintenance. So this started off, first, can we track residents and understand duty hour violations? Because we don't believe self-report duty hours are accurate. And from that expanded to, well, can we look at workflow and try to redesign some of the work so it's a better experience for people? So looking at time they spend, that's a value add, and time they spend that's inefficient. And can we, again, move trainees and learners back to the bedside to get them more time with patients is one of the. So this is about 45,000 hours generated from 43 interns. This was a pilot study to just look at the efficacy of this. It took a lot of work to clean the data and the process the data, but we're getting something very usable from this. And just for some context, this across the bottom is just the minute in a 24-hour day, and up the y-axis is the number of hits. So the number of times that an individual is identified as being in a specific physical location. This is collapsed across all of the 45,000 hours. And for point of reference, when we looked at the time spent in different locations, it was almost identical to the largest time and motion study, multi-million-dollar study just conducted a few years ago, and their total amount of time was 2,000 hours, and they spent millions of dollars to do that. We generated essentially very similar results for the cost of $43, $25 badges. Of course, it's not exactly the same, but the broad strokes are very, very similar. So you can see kind of when people come in, when they go out, you can identify different types of activities. This is where they're attending different conferences and lectures, the blue or teal, I suppose. And you can identify pre-rounding activities in there, when the uptick when they're in ward halls and patient rooms, and also the actual roundings where they spend a lot of time walking through the ward halls and the patient rooms. So this is a way to scale up a very rich sensor data set that we can collect from a small number of people and find some meaningful patterns. And we're in the process now of finding some of those same kind of workflow patterns that were there in the movement, the entropy and the burstiness of movements. Do those matter for the trainees' experience, both educational outcomes and training outcomes? Those questions will be hopefully answered very soon. But these things do scale. This is a cheap inbuilt system that we plan to layer on also EHR metrics to better understand workflow and work practices. So this scales up also to another study we're doing right now. This is kind of ongoing, so unfortunately I won't have too much data to share, but we'll talk about how it's designed to scale up from the individual to the team level. We're really looking here at kind of how teams manage kind of chronic and acute stressors. So being a part of a really challenging 40-bed pediatric intensive care unit that has high levels of stress, that has high levels of burnout just on a day-to-day basis, and how that relates to the acute stressors. And these are code team events. So this is cardiac arrests, this is ECMO, this is difficult airways, there's things like that that require an acute response from the team, and how that impacts individual and team kind of performance outcomes. And then two, we're looking at how do they interact as a team, and how does that protect them from the effects of both chronic and acute stressors, or help them, or make it worse. So the measurement plan we're focusing on here is combining a lot of those same data sources. We're using the administrative data on patient acuity scoring systems and things like that. We're capturing self-reported stressors, the types of interaction patterns. We've done some interviews and focus groups to understand what, from a day-to-day basis, are the things that contribute to people's stress the most, just like we did at the individual level. And then we're recording their stress responses, both from self-reported measures and emotional state recognition from physiology and from speech features. And then we're also, for the teamwork domain, we're looking at self-report measures of process in general for kind of normal team functioning in the unit, as well as for those code events, a scale developed specifically for those crisis events. And then we're also looking at interaction patterns derived from the data, so the movement and co-location patterns and communication flow between people. And the outcomes we're looking at are kind of individual burnout, team affect in terms of trust and efficacy, and objective task outcomes, which are tough to come by for just a unit functioning, but we're looking at kind of response to emergencies, response time as a measure of spare capacity in the unit, and the quality of CPR delivered during those codes for which CPR was required. we're using a collection. So we've moved from, and I think this is a trend that's broadly happening, is we've moved from a dedicated sensor system, so that one thing that people put on and wear, to a collection of different sensor systems that get at different things and do it better. So we're using our inbuilt location tracking system to look at patterns of collocation and physical workload. We're looking at a wrist-worn physiology monitor that captures cardiac and electrodermal activity. These are a commercial device. They're not cheap, but the data is pretty good as far as these things go. It's as good as you can realistically get with a wrist-worn device. But those are they're doable for smaller studies like this. And the smartphones we're using for emotional state recognition and team interaction patterns, and also completing survey responses. So again, very similar, and I think this is something that comes up again and again in our work and others that we read, pairing the sensor data with an experience sampling methodology. So we're capturing, they come in for the beginning of their shift, they put on all their sensors, they fill out a survey, and they do a pre-survey at the beginning of the day, and they fill out surveys at various time points throughout the day and after each code event that they see. We'll go quickly over this to save some time for discussion, but this one really focuses on applying those exact same sensor streams I talked about and analysis methods to inferring things about the individuals on the team. So we were really fortunate to have a project over the last few years, and it's going for the next few years, on NASA for astronaut selection. So they're trying to pick people who will be effective team members for long-duration missions, so up to 3 years for a Mars mission. One of their biggest identified risks for the kind of behavioral health of the team and the crew are people's social skills, because you're no longer a crew, you're basically a family living together for 3 years. How do people deal with the isolation and managing conflict and a lot of those things of just getting along together? Those are really hard to assess, and they're easy to fake for very short periods of time for smart, motivated people. So the thought and the idea is that there may be signals in these types of data that are more difficult that are predictive and more difficult to fake over short periods of time. So we'll see how that goes. So in the short, across all of these studies, and I understand this may be kind of all over the place, but there's some unifying themes in terms of the types of data we use. So far in the studies we're conducting and the pilot data we have, that these types of measures predict outcomes well, particularly experience outcomes, in ways that some of the current methods don't. And they're, of course, much more scalable. The team interaction patterns are technically more challenging many times than individual work patterns, but we think moving, from old systems to more effective, more modern systems will help a lot, but it's still very, very challenging. There's a lot of work to be done there. And again, the experience sampling approach to capture within individual, within team, and between individual and team variance seems to be really helpful to sorting out these measurement systems and validating them. And again, the goal is to work from a full set of measures. Let's capture what we can if it's cheap and easy, but let's sort through to what matters most so that we can either stop collecting or stop looking at the things that don't matter. If we don't need all vocal features, let's not capture that, because that is a little more intensive. If we can get good proxies off of physical movement or access logs for the EHR, let's do that kind of thing. So a few more kind of practical projects I'll go through quickly. This came out of the need for handoff improvements in our health system. And this is an overview of a study which is 5 years old now and is really kind of the high water mark in terms of effective handoff improvement programs and their evaluation. Handoffs have been in transitions of care, have been a known issue for a very long time. You can get them better. And this study shows, implementing an improvement program decreases medical errors, decreases adverse event rate, and preventable adverse event rates, and the program have improved the quality of the process of handoffs, so more inclusion of key handoff elements, and they did that without really dramatically improving the amount of time people spent doing handoffs, which is good. And if you look at what they actually did to achieve that, it's standardized oral written handoffs, it's a training program, it's a faculty development program, there's an observational rating and feedback program, and a sustainability campaign. So they did all of the things you're supposed to do. Again, that's really labor intensive, and this was just for one piece of the handoff puzzle. This was a resident-to-resident handoff in one department, so a lot of time and effort to get those gains. You can do it, but can you scale that? It's not clear, and one of the things we were charged to do is try to improve handoffs across the health system. The first thing we did is, well, where are they happening, and where's our biggest handoff risks, and where's the best target for improvement interventions? So what we did is go through and look at our patient movement data to see where are patients being transitioned in our health system, and this is what we got. So this is 3 months of data, about 12,000 patient admissions in a 1,000-bed hospital, 108 units here you see on the left. That's generally patients being admitted, and it's progresses to the right for discharge. So each block is a physical location in the hospital, a unit. The bigger the block, the more patients moved through that unit in the period. And all the lines, of course, are patients moving from one unit to another. The bigger the line, the more patients moving through that. So when we did this, one of the first things we thought was, well, no wonder the kind of dyadic model of handoff improvement is not working. This is really not working well. That's because this is incredibly complex. For 12,000 patients, there's almost 3,000 unique ways to get through our hospital. Each patient had, on average, over 3 inter-unit handoffs, not counting all the intra-unit handoffs that happened. So our hypothesis of where you would focus on this was, well, it's probably people's perceptions of how well they're doing is probably going to be driven by kind of the upstream complexity. Wherever I sit in this system, if what's on the receiving end to me is highly complex, I'm going to think we do a really bad job with handoffs. And also maybe the variety of the places I get patients from could be a source of handoff risks. Or maybe the turbulence or the temporal unpredictability of when I'm receiving patients could play into some handoff risks. So we started going through and generating a lot of those different metrics from the system and looking at, we have, regularly occurring surveys that include dimensions around teamwork across hospital units. So we said, well, are there things about structurally where these units sit and relate to one another that are going to impact how well they believe they're doing it as coordinating across units? And we know, too, those teamwork across unit scales are predictive of outcomes at the hospital level of adverse events hospital. So it's meaningful information. So we generated a bunch of measures around that system, the traditional things about the unit, the bedside, the churn, the length of stay, some of the temporal features of transitions, and then some of the structural features, like just basic network measures of the units in that system. And this is preliminary based on a small subset of those hospitals. One of the challenges using found data is survey data is collected on an organizational level, organizational unit. This type of data is collected at a physical location, and those don't map onto each other clearly all the time. So we had 43 of the 108 units that clearly matched in terms of the people filling out the survey and the patient movement through that physical space. What we found is that you believe you're doing a much better job with handoffs, and then as a proxy you're doing better coordinating across units the more that you are on the highways to those units. So we talked about, I think I maybe skipped over the idea that there's highways in which most of the patients flow through certain paths, and then there's byways, your unit's on a lower frequency kind of trajectory through the hospital. And between the centrality is just how much your unit is plugged into the overall center of those connections. And the last indicator there is just the average degree, neighbor degree. That's also the degree to that the people you're connected to are connected to lots of other units. So it's really also, too, how much you're on those highways in the units, for lack of a clearer explanation. Those all impact positively people's perceptions of how well we coordinate in the unit. So it's a little bit contrary to what we kind of thought it would be. More of the risk appears to be on the byways, which does make sense versus the highways. And the other one was surprising, the burstiness of discharges during the night shift was positively related to how well they do that. But if you looked at it, those because they were all clumped up towards the beginning of the night shift, and you weren't just trickling them out overnight. So people had a much better perception of that as well. So the last one, and I'll go through this a bit quickly, just running out of time. But we're looking at event reporting systems. And if folks understand, spend some time with patient safety event reporting systems, there's a lot of question about the overall utility and value of these things. It was adopted from the aviation industry. They are not perhaps used as effectively as they could be. On average, you get about 1,000 narrative reports. We get 1,000 narrative reports per month. It's usually one per hospital bed is a rule of thumb of what you'll usually get. We get a little bit less than that. But still, that's 1,000 roughly narrative reports a month that someone needs to read through, analyze, understand what went wrong, generate a solution, implement, and evaluate, ideally, what's going on. That clearly doesn't happen most of the time. The very important things rise to the top, get some attention, but a lot of things get ignored, and a lot of people spend a lot of time just classifying things. So we went to apply and develop some natural language processing techniques to all of this narrative unstructured data and to assess the validity of doing that. So we'll talk about what topic modeling is real quick, but basically, can we find patterns in this data that we didn't know about already, and are those patterns coherent and meaningful, but also do they predict the things we care about, in this case, patient harm for these event reporting examples. So briefly, what you do, if you're not familiar with topic modeling in general or latent semantic analysis, similar things, what it does is, as we're generating some text, some document, we're speaking, we have an idea in mind. That idea is going to change the probability of the words that we use in generating the text. So for example, topic 1 here is around a medication error. Words that you would are highly likely to use are medication, dose, route, pump. In the formal modeling technique, all words in a vocabulary have a probability. So things like, you would be very unlikely to say tomato when you're thinking about a medication error. The second topic is around a communication error. You would say things like call, communication, unresponsive, verbal, and again, very unlikely to say tomato unless you're talking about a tomato. So those, if you're thinking about those ideas, those are the types of documents you generate. And documents can be generated by a mixture of different topics too. So at the top is a pure medication error. The patient's on an infusion pump and received the correct dose of medication due to improper dilution. The bottom one is a pure communication error, using those types of words you would see associated with a communication error. And in the middle is a mix. We had a medication error that involved poor communication, that stemmed from poor communication. So really what you're trying to do with a topic modeling approach is you're starting with what's in the middle. You're starting with all the documents, and you're trying to infer what those topics are. You don't know what the topics are. You don't know the distribution of words within those topics, and you don't know the mixture of where those documents came from. So this is very much a generative modeling approach. There's a lot of challenges to this, but it produces really interesting results. So what we did is we did that modeling technique over about 13,000 reports, generated a 40-topic model, and then we had experts, people who work with the event reporting system in our patient safety office all the time, sit down and look at all those and evaluate those. And that was about 9 hours to get them to go through all this, where you look at the top terms, where you look for each topic, and you look at representative documents and had them judge, is this a coherent thing? Is it important? Do we already know about this? Is it represented well in our current event taxonomies? And then we use the scores from those topics to predict things, to predict harm scores. So for example, these are some of the topics that came out. So if you read those terms, you can guess, if you've spent any time working in safety and hospital management. Topic 1 is about blood products. Topic 2, infusion, heparin, rate, drip, weight. Those are heparin or high-risk medication errors. The middle one is clearly about patient falls. Topic 4 is about pressure ulcers or wound care. And the last one was a little bit unique. It was a collection of errors found at shift change, which is also something that happens. So overall, almost 3/4 of those topics were rated as highly coherent, and only 2 of them out of the 40 were judged to be junk, which happens with these models. It'll turn up just a statistically valid but conceptually malformed kind of topic. It doesn't really mean anything. And of those, there were 14 topics that the experts rated as highly coherent and important that we didn't represent well in our current topic system. So 14 trends or things that were happening in our safety event reporting data that we weren't really tracking clearly or weren't really represented well in our event taxonomy. So this is telling us something new that we didn't know about our data. And this will, too, kind of map out some of those, basically this is telling us that some of the patterns are hidden across multiple categories. For example, patient aggression, which is a topic identified by natural language processing, was really hidden. The magnitude of that was hidden across security issues, behavioral event, inappropriate behavior, injury, and assault, 5 categories to represent one pattern of behavior that needed managing. So this is a really valid thing to do. And our next steps really look at taking some of this data. We can now look at how people are telling these stories about patient safety over time and how that changes and evolves over time. There's something in the organizational science that looks at narrative dynamics and how the storytelling about our organization changes over time. This is a great way to do that, to generate some measures of climate around how people are telling stories about safety and quality, and do that in an empirical way. So in sum, we're really strong with these methods in terms of description and prediction. Explanation piece takes a lot of work, and that's where we need to better coupling with the social sciences to have better explanatory models of why these things are working. And we've really only started to scratch the surface in terms of interventions for how we can control our organizations based on this type of data. So there's a huge opportunity in terms of reduced burden of data collection, the increased scale of data collection, and using multiple methods to triangulate to know more about our information, know about our organizations. We're essentially reducing the cost of knowing important things about our organizations. We can build better selection systems, better work redesign, monitoring systems, feedback systems. But to get there, we really need better integrated frameworks, which we're struggling with right now. We have lots of projects in this area. There's got to be a better way to think about them and talk about them and communicate them. There's clear threads across them, but it's a struggle with the state of the methods in the frameworks available to date. Spend a lot more time with measure validation. We need technical infrastructure to do this work. Right now, we're at the mercy of what's being built for precision medicine infrastructure, for example, for accessing the EHR, which does not include the types of information that are going to be most useful for these types of problems. It's just clinical data. It's not use data. And human capital. We need the right kinds of people to get this work done. And with that, I will stop there. I apologize for going a little bit over, but appreciate the time and attention.
Thank you so much, Dr. Rosen. That was a great presentation, and I'm sure everybody shares the same sentiment. Since we are at time, if anybody that is currently on the line has any questions for Dr. Rosen, his email is up on the screen if you would like to reach out and get some of those questions answered that you might not have gotten answered during today's session. So I want to be respectful of everyone's time, and we are at 1 o'clock now. So thank you again, everyone, for joining, and thank you, Dr. Rosen.
Thank you.